Hello, everybody, and thank you for joining us. My name is Dr. Alexander Feoktistov. I'm a physician and director of clinical research at the Diamond Headache Clinic in Chicago. I'm also president-elect of the American Interventional Headache Society. Today, we're going to be talking about migraine, and specifically, we will focus on migraine therapy. Before we dive into discussion of migraine therapy, it's important to recognize that migraine is one of the most disabling primary headache disorders, and it's certainly one of the most prevalent primary headache disorders. It has been estimated that migraine headache affects about 18% of the United States female population and up to 5% of the United States male population. Although migraine affects different age groups, it has been also estimated that migraine predominantly affects patients during their most productive years. Thus, about 25% of females between the ages of 29 and 39 would experience migraine headaches. Migraine diagnostic criteria are quite simple and straightforward. We expect patient to have a history of at least 5 attacks that would fulfill the following criteria. First of all, duration of the pain. Classically, migraines last between 4 and 72 hours. What we see in clinical practice, typically that patients report headache lasting between 24 and 48 hours. In addition to the duration, this headache should have at least 2 of the following characteristics. The first one is location of the pain. Typically or classically, migraine is a unilateral headache, usually affecting one of the temples. It is not uncommon, though, to see patients with bilateral headache distribution or holocephalic headache when the entire head is involved. It is also not uncommon to see patients who would report that their headache switching sides, either between different attacks or even within the same attack, when it starts on one side and then transitions to the other side as the pain progresses. Patients frequently describe migraine pain as being pulsating or throbbing in quality. This pain is usually at least of moderate but frequently severe in its intensity, and it's frequently causing avoidance of routine physical activity such as walking or climbing stairs. This headache should also be associated with at least one of the following symptoms, either nausea or vomiting, or photo or phonophobia. So typically, if you have a patient with a migraine in front of you, this patient would typically describe their headache as moderate to severe in severity. They would describe the pain as being throbbing, either unilateral or bilateral, associated with at least nausea and some sensitivity to light or noise, and that pain is usually lasts about 24 hours. So that's the typical, most common presentation of a migraine headache that we see in our clinical practice. When we talk about migraine, we frequently focus just on the headache itself, which is not very accurate. Migraine as a phenomenon consists of different stages, or it goes through different phases. The first phase is the prodromal phase. During that phase, patients experience extreme and frequently unexplained fatigue, increased irritability, certain food cravings, increased anxiety or worsening depression, insomnia. During that phase, patient may not have any headache at all or may have very mild non-specific headache, more like a dull pressure-like headache. That prodromal phase typically would last from few hours and up to 72 hours prior to the headache onset. The second phase is migraine aura, which is a very interesting neurological phenomenon that consists of certain neurological symptoms that gradually evolve over the course of 5 or 6 minutes, and they progress and completely resolve without any residual symptoms within 60 minutes prior to the headache onset. There are different types of aura depending on the symptom that patient experience. The most common type of aura is visual aura. During the visual aura, patient may start seeing spots or flashing lights or scintillating scotomas. They may also experience distortion to their visual field. And again, all of these changes gradually evolve and resolve completely without any special treatment within 1 hour prior to the headache onset. Another common type of aura is a sensory aura, during which patient may experience either numbness or tingling, usually on one side of their body, such as, for example, half of the face or one of the arms would be affected. And again, we do expect complete resolution of those symptoms within 60 minutes prior to the headache onset. Patients may also experience with distortion of their speech, so-called aphasia, when the speech becomes very slurred. They may find it difficult to express themselves during migraine aura. And on rare occasions, patients may also experience a true unilateral weakness. Unilateral, contralateral to the headache for that matter, when patients might experience weakness of one side of their body, their face would start drooping, or they experience profound weakness in one arm or one leg. This is so-called the hemiplegic migraine, which is fairly infrequent, and usual patients, when they experience the symptoms, they definitely appear in the emergency room with stroke-like symptoms, and sure enough, all their neurological workup that is being done as usual turns out to be negative. And again, we still expect a resolution of those symptoms within an hour. So that being said, if you have a patient who is experiencing any of those neurological symptoms that last more than 60 minutes, you really need to investigate it a little bit further just to make sure that you're not missing any other neurological condition. The third phase is a migraine phase itself that we just discussed. That's presented as throbbing, typically unilateral or bilateral pain associated with sensitivity to light, loud noises or loud sounds, nausea, occasional vomiting, and frequently neck pain. So, in fact, it has been estimated that neck pain is as prevalent as nausea in patients with migraine. It affects about 70% of migraine patients. So, if you have a patient in front of you who is describing their headache as originating in the occipital area or upper part of their neck or cervical area that's spreading unilaterally or bilaterally, I don't want you to think tension type headache or cervicogenic headache, as it might be still a quite classical presentation of a migraine headache. And after the headache phase resolves and the pain subsides, patients enter the so-called postdromal phase that may last up to 24 hours. During that phase, patients frequently may experience some lingering low-grade headache, and they still experience significant fatigue, still some irritability, inability to focus. So typically some degree of disability might still be present during those several hours and up to 24 hours after the headache itself. So in a nutshell, if you look at those phases of migraine, if we're talking about the migraine pain duration, we always say it's between 4 and 72 hours, but the entire migraine phenomenon, which could be quite disabling from the beginning till the end, could actually involve up to 7 days, and that's really important to recognize. Clinically, we divide patients with migraine into episodic migraine patients and chronic migraine patients. Patients with chronic migraine experience at least 15 headache days per month, and 8 of those 15 headache days should meet migraine criteria. And obviously, those patients with episodic migraines would experience fewer than 15 headache days per month. And this division is definitely clinical based on the headache frequency. And it is important not only from the classification standpoint, but it also guides our therapy. So since we're talking about the therapeutic approaches, there are 2 major categories of therapeutic approaches that we have in our arsenal. There's an acute therapy, so-called abortive or rescue medication that patients are using as needed, typically at the onset of the headache. And all patients with migraine headaches, whether episodic or chronic, should have in their arsenal an effective, reliable acute medication. We'll talk about those in a few minutes. Prophylactic medications is typically not for everybody. So if you have a patient in front of you who is a chronic migraineur, who is experiencing more than 15 headache days per month for at least 3 months, those patients should definitely be on a prophylactic medication. That's an easy choice. But how do you approach those patients who have, let's say, infrequent or frequent episodic migraine, let's say 4 or 5 headaches per month? Would you treat them with a prophylactic daily preventative medication? So I'll give you 2 case scenarios to make that more clear. So if you have a patient, let's say, who's experiencing 4 to 5 migraines per month, and that patient is using the rescue medication at the onset of the headache, and typically within 1 to 2 hours, patient becomes headache-free or almost headache-free or symptom-free, and they continue to function. They don't really experience significant disability due to their headaches because they do have good rescue therapy available to them. So would you start this patient on a regular pharmacotherapy to prevent their headaches? Probably not. Seems like there's a very little disability or almost no disability associated with the headaches. probably should not be on a prophylactic medication. And then you have another patient with a similar headache frequency of 4 to 5 headaches per month. This patient is using one type of rescue medication, then another one, and still find those medications being ineffective, or they're not able to tolerate those medications. And those 4 or 5 days out of a month, at least on half of those days, patients are not able to attend work, or they're missing school or social events. So there's a significant amount of disability associated with those headaches. That patient should definitely be on some type of prophylactic therapy. So that being said, what I want you to capture here is that it's not only the frequency of the headache that determines whether we need to use a prophylactic medication or not, but overall the disability. So in my mind, disability is more important than the frequency in that sense. Now let's talk about available acute treatment options. Before we go into details, a couple of important points. The idea behind acute therapy is to provide patients with rapid, if not immediate, symptom or headache relief. These medications are designed to be taken not daily, but only on as-needed basis, and the frequency of acute medication use should not exceed 2 days per week, regardless of which acute rescue medications we're talking about. This is in order to avoid development of so-called medication overuse headache. Also, considering a very complex pathophysiology of migraine, it is highly recommended that acute rescue medication should be implemented and used as early as possible at the onset of a migraine headache. There are several families of acute or rescue medication that are available. Historically, the first family that became introduced to the headache field was a family of ergotamine-containing medications all the way back in 1928. And even to this date, we still use ergotamine-containing medications in our clinical practice with great success. The most common representative of this group is the dihydroergotamine nasal spray. There's a dihydroergotamine IV infusion and IM injections. In fact, we frequently teach our patients how to administer intramuscularly dihydroergotamine, and they can use it safely in the comfort of their home to treat those really refractory to therapy and intractable headaches. IV infusion of dihydroergotamine typically requires hospitalization and close monitoring, considering that this medication is highly vasoconstrictive, so the blood pressure needs to be monitored routinely, EKG occasionally. And typically patients during the course of that therapy would receive 0.5 to 1 milligram injections, or rather infusions, which it's a slow infusion which is run over the course of 60 and up to 120 minutes, so it's fairly slow infusion, and patients would receive one of those doses, again either 0.5 milligrams or 1 milligram intravenously every 8 hours for a total of 9 doses. So this is so-called the DHE 45 protocol. Although this medication is very well tolerated, the most common side effect that we do see pretty much routinely in our practice is severe nausea. So we typically recommend to pre-medicate dihydroergotamine IV infusions with some type of antiemetic. We typically use ondansetron, but any other antiemetic might do the job. And finally, ergotamine comes as the oral formulation or sublingual formulation as well that's available now. And again, patients would be using that as needed, not exceeding 2 days per week. The most common family of rescue medication that were used to date is the triptans family, and they were introduced in the early 1990s. The very first triptan that was introduced was the sumatriptan. It became available as early as in 1991, and this type of treatment comes in every shape and form. It comes as a tablet form in different strengths. It comes as a sub-Q injection, also available in different strengths now. It comes as a nasal spray and nasal powder. There's also a combination formulation of sumatriptan and naproxen. Other triptans that are available on the market right now are zolmitriptan, rizatriptan, naratriptan, almotriptan, frovatriptan, and elatriptan. Non-steroidal anti-inflammatory medications might be used with great success for the acute therapy of migraine headaches, yet the only one NSAID that has been FDA approved for migraine therapy is diclofenac powder. This medication should be diluted in a small amount of water, about maybe 1 or 2 ounces of water, and taken again at the onset of the headache. The frequency of use of this medication should not exceed 2 days per week, once again in order to avoid the development of medication overuse headache. Every effort should be made to avoid using opioids and butalbital containing medications for an acute therapy of migraine headaches, simply for two strong reasons. One is obviously an abuse potential, and second is, again, the high risk of development of medication overuse headache. And I'm not saying that those medications do not have its place in headache medicine. They certainly can be used occasionally, but these medications should never ever be the first or the second or even third line treatment option. Although all of the triptans share the similar mechanism of action, they have similar efficacy, similar side effect profile. There are certain differences between different triptans. The first important feature is the half-life. As you can notice from this table in front of you, that most of the triptans have a fairly short half-life, spanning from 1.5 and up to 3 hours. So they're a very short-acting type of medications, except maybe two medication. The first one is, it's a longer acting medication. The first one is called naratriptan. Its half-life consists of 5 to 6 hours, and the longest or the triptan with the longest half-life is afrovatriptan. Its half-life is 26 hours. And then another distinguishing and very specific feature of all of these different triptans is the onset of their action. So the fastest acting triptan, obviously injectable, sumatriptan. Patients experience 50% reduction of their headaches as soon as 30 minutes after the injection. The slowest acting triptan is the frovatriptan. It may take 4 hours for the patient to start experiencing reduction in their pain. And also, how do we administer those medications? So some of the medication available as the tablet form, some of them available as a tablet but oral disintegrating tablets, some of them available as a nasal sprays or subcutaneous injection. So all of those things do matter, and I do think when we have a patient with migraine in front of us, we can tailor and choose a very specific triptan for that specific patient based on the clinical presentation. So what do I mean by that? So for example, if we have a typical patient with migraine who is experiencing rapidly evolving a migraine that typically takes patient from being pain-free to a severe pain level within 1 to 2 hours. For those patients, you definitely don't want to use a medication that would take 4 hours to work, like frovatriptan, but you want to use something that's going to work very fast. So faster acting medications for those rapid onset headaches. From the other hand, you may also have a patient who is experiencing long-lasting migraines that last 3-4 days sometimes in a row, like menstrual migraine, for instance. For those patients, you might want to utilize those longer-acting medication with longer half-life, such as naratriptan and frovatriptan. And finally, if you have a patient in front of you who's experiencing significant nausea or vomiting as part of their migraine presentation, you may want to consider non-oral administrations of the medications such as sub-Q sumatriptan or nasal spray, nasal powder of some of the triptans, and that might be much more effective than the oral formulations. Overall, triptans are very well tolerated. Occasionally, patients may experience some chest tightness or chest heaviness and fatigue, but usually in those cases we recommend patients to try a different triptan, and frequently you'll find that if one triptan was ineffective or poorly tolerated, patients might find another triptan much more effective and they can tolerate it significantly better. Relative contraindications to triptan therapy is a poorly controlled or uncontrolled hypertension, because all of the triptans and ergotamine containing medications are vasoconstrictive agents, so we typically do not recommend using them in patients with poorly controlled hypertension. This medication should never be used for patients with coronary artery disease or history of coronary artery disease. This medication should not be used for treatment of patients with migraine with brainstem or hemiplegic migraine, with those with stroke-like symptoms. This medication typically is not recommended for patients with severe liver and kidney damage. Patients who are taking MAO inhibitors should not be using triptans, with few exceptions, but we're not going to go into details of that. And routinely we recommend to avoid using triptans during the pregnancy, since the safety profile are not quite well studied in that population of patients. Another important considerations are whenever you have a patient who must have two different triptans or who must have in their arsenal both ergotamine containing medication and the triptan, this medication should never be mixed or used together within 24 hours. So that being said, if patients using, let's say, different formulation of the same triptan, for example, an oral formulation of sumatriptan and injectable sumatriptan, these two options could be used effectively within 24 hours because chemically it's the same medication. But if we're talking about different triptans or we're talking about triptan and ergotamine combination, those medications should always be used at least 24 hours apart. You also may have heard about the risk of serotonin syndrome in those patients who are using triptans while being on either SSRIs or SNRIs. The risk of serotonin syndrome is extremely rare. This combination of medications have been used routinely. We still encourage physicians to educate their patients about serotonin syndrome, especially those patients who happen to be on 2 or 3 serotonergic drugs and we're adding another triptan. It's not a bad idea just to mention to the patient that they should use those medications with caution, although again, serotonin syndrome is extremely rare. And as a rule of thumb, whenever we talk about acute therapy, no matter which acute medication we're talking about, this acute therapy should be limited to 2 doses per day and no more than 2 days per week, primarily to avoid or prevent risk of medication overuse headache development. Now let's talk about the prophylactic treatment options. A couple of important points about prophylaxis. First of all, the idea behind the prophylaxis is prevention of future migraines. So we're not talking about headache freedom in that case, we're talking about reduction in migraine and headache frequency over a period of time. It usually takes 4 to 6 weeks for the patient to start experiencing this positive improvement. We're also looking into reduction in migraine-related disability and also improvement in overall quality of patients' lives. So that should be discussed with our patients so that they have realistic expectations. It is also important that whenever we prescribe prophylactic medication, we typically start at a smaller dose and titrate them up to a therapeutic level based on patients' tolerance or side effects. There are several families of medication that have been approved for episodic migraine prophylaxis. And one of the family that we use regularly is the beta blockers. There's quite a few beta blockers on the market that could be used successfully for migraine treatment. The most common one would be propranolol. Therapeutic dose ranges between 40 and 240 milligrams per day. It is recommended that patients be started on a smaller dose, maybe 20 to 40 milligrams at night, and the dose should be increased gradually. We recommend patients to monitor their heart rate and their blood pressure. And also, it is not a bad idea to monitor mood changes in those patients with poorly controlled depression, as some of the beta blockers can worsen some of their depression symptoms. Anticonvulsants is the second family of prophylactic medication that is commonly used for migraine prophylaxis. The first one is topiramate. At this point, topiramate comes in 2 different formulations, which is an extended release and immediate release formulation. If we're talking about extended release formulation, the entire daily dose should be taken only once at night, usually at night. We typically start patients at a 25 milligrams nightly and titrate the dose up gradually by increasing their total daily dose by 25 milligrams weekly up to a target dose of 100 milligrams per day. If patients are using immediate release formulation of topiramate, the total daily dose should be split in 2, and patients should be used 50 milligrams in the morning, 50 milligrams at night. Again, we start at a smaller dose, 25 milligrams, and titrate it up gradually. D-valproic sodium has also been commonly used for migraine prophylaxis. Again, we typically start patients at 250 milligrams at night and we titrate the dose up weekly up to a total target dose of either 500 and up to 1000 milligrams at night. Certain triptans can be used for migraine prophylaxis, and we have 3 triptans that were specifically approved for a short-term prophylaxis of menstrually associated migraine. Those are the migraines that occur during the menstrual cycle. And the triptan that we use for that purpose, for that indications, are frovatriptan, zolmitriptan, and naratriptan. Those are the triptans with the longer half-life. And it is recommended to use those medications for those patients with regular menstrual cycle when menstrually associated migraines are quite predictable, and we recommend patients to start using those medications either once a day or twice a day for 3 or 4 days in a row to prevent those usually difficult to treat migraine headaches. Certain antidepressants can be used with great success for migraine prophylaxis. The classical example would be the old tricyclic antidepressant called amitriptyline. The therapeutic dose again ranges between 25 milligrams at night and up to 100 milligrams at night. We once again recommend to start patients at a smaller dose, maybe 10 to 25 milligrams, and the dose should be titrated up gradually. Other tricyclic antidepressants can be used with the same success, such as nortriptyline or protriptyline, depending on the patient's preference and patient's clinical situation. Selective serotonin norepinephrine reuptake inhibitor venlafaxine has also been showing good results in migraine prophylaxis, and the target dose for this medication is 150 milligrams per day. Other blood pressure medications such as candesartan and lisinopril can be used for migraine prophylaxis. These are new additions to our toolbox. There are more and more publications coming out indicating the efficacy of these medications and their safety, yet they're not still considered to be standard of care, so definitely should not be used as your first or second line option at this point. Interestingly, that calcium channel blocker verapamil has been used with good success in migraine prophylaxis for the past many years. The therapeutic dose ranges between 180 and 360 milligrams per day, and although we're using it in our clinical practice routinely, we unfortunately don't have a very good or strong scientific support for this medication. Onabotulinum toxin 8 has been FDA approved in 2010 for chronic migraine prophylaxis, and up to this year it was the only medication that was approved for chronic migraine prophylaxis. There have been 2 major trials, PREEMPT 1 and PREEMPT 2 trials. So if you're interested, I would encourage you to look into those trials that evaluated the efficacy and safety of the onabotulinum toxin type A in patients with chronic migraines. It is indicated for patients who experience at least 15 headache days per month for at least 3 months, with 8 of those 15 headache days meeting migraine criteria. And typically we expect that those patients should have failed at least 1, 2, or 3 preventative medication before onabotulinum toxin A would be approved. When we talk about onabotulinum toxin A for chronic migraine treatment, we're talking about a very specific chronic migraine paradigm, which is in front of you. And this medication is injected across 31 injection sites for every single patient with chronic migraine, regardless of their pain location. It's really important. We no longer follow the so-called follow the pain pathway. It is recommended to inject those symmetric sites for every patient with chronic migraine. This is a so-called chronic migraine paradigm. Again, we inject 31 sites. Each injection consists of 5 units of onabotulinum toxin A, and patients should get 155 units as a result of that one single treatment. This treatment should be administered every 3 months. Typically, we expect patients to start noticing some positive improvement within 2, maybe 3 weeks, although it's not uncommon for the patient to be needing to have 2 to 3 treatments before they start seeing the full effect of that therapy. And finally, I wanted to talk to you about this new family of migraine preventative medications that became available in 2018, which are calcitonin gene-related peptide monoclonal antibody, or simply CGRP monoclonal antibodies. CGRP monoclonal antibody is the family of prophylactic medications that were specifically designed and developed for migraine prophylaxis. Calcitonin gene-related peptide is one of those physiological neuropeptides that we all have in our system. Its main physiological function is to produce vasodilation. It was also later discovered that CGRP is heavily involved in pain processing as well. Back in the early 1990s, we have also discovered that plasma concentration of the CGRP increases dramatically right at the onset of a migraine headache. And if you treat those patients with, let's say, injection of a sumatriptan, that would bring the CGRP level down dramatically as well, and that would correlate with pain relief. And more so, if you take a group of patients with history of migraine headaches who are pain-free at the moment, and if you inject those patients with CGRP intravenously, majority of those patients would experience migraine-like headache within an hour. And this is how this whole family of the CGRP monoclonal antibodies were developed. At this point, we have 3 FDA-approved CGRP monoclonal antibodies on the market. They're all indicated for patients with migraine headaches who experience at least 4 migraine headache days per month or more. The first CGRP monoclonal antibody that was approved is erenumab. It became available in May of 2018, and this is the 100% human CGRP monoclonal antibody that targets CGRP receptor. It comes at 2 different strengths, 70 milligrams and 140 milligrams, that patients can administer subcutaneously once a month. Again, it comes as an auto-injector, so patients should be able to administer this medication themselves in the comfort of their home. The most common side effect from erenumab is mild constipation and injection site reactions such as itching or redness. Most of the time, these side effects are quite mild and do not require any special treatment. The second CGRP monoclonal antibody that became available in October of 2018 is fremanezumab. This particular one is the humanized monoclonal antibody that targets CGRP ligand, not the receptor. This particular CGRP monoclonal antibody comes in the form of a prefilled syringe. Each dose consists of 225 milligrams that patients can administer subcutaneously themselves once a month, or they may choose to inject 3 injections at the same time for a total of 675 milligrams, and they inject it again subcutaneously, and they can do that quarterly thereafter. Again, this is designed to be administered by patients themselves. The most common side effect from fremanezumab is an injection site reaction, which is again either redness or itching or swelling, which is usually very mild and self-limited. And finally, the third one that became available also in October of 2018 is galcanezumab. This medication also a humanized monoclonal antibody that targets the CGRP ligand. And this medication comes as an auto-injector that, again, patients can use themselves once a month at home. We start the therapy with a loading dose of 240 milligrams subcutaneously times 1, followed by 120 milligrams 1 month later, and patients continue to inject 120 milligram dose monthly thereafter. Again, very well tolerated medication, with the most common side effect as being, again, injection site reaction, which is mild and self-limited. The fourth CGRP monoclonal antibody that is currently undergoing phase 3 investigation is eptinezumab. This specific one is also humanized monoclonal antibody against the CGRP ligand, which will become available as an intravenous infusion that should be administered to our patients quarterly. There are other non-pharmacological treatment options that we recommend to use routinely with all of your patients with migraine headaches, chronic or episodic. The first one that we always recommend is we ask patients to follow so-called low tyramine and low caffeine diet. Tyramine is a natural occurring substance. It's essential. It's a product of fermentation. So most of the products that have been fermented or aged, they will release this tyramine, and that's a very potent trigger. So patient needs to be educated on that. We provide those patients with the low tyramine diet, and we ask them to follow this diet. Typically, if patients consume high tyramine containing product, we expect them to experience a headache within several hours after they consume this product. We recommend patients to maintain regular meal pattern and meal schedule, never skipping a meal. It's really, really important. We recommend our patients to have regular sleeping schedule with going to bed and waking up times being the same every day. We recommend patients to learn and practice biofeedback, which is a method of controlling body temperature and muscle contraction, muscle tightness. And this has been also shown to be very beneficial in patients with migraine headaches and also tension type headaches. We recommend stress management and even psychotherapy or counseling for those patients who report stressors being a major trigger for their headaches. There are a couple of other non-pharmacological treatment options available at this point for our patients. The first one I wanted to talk to you about is a non-invasive vagus nerve stimulation marketed under the brand name of GammaCore. It is FDA approved as a rescue therapy for migraine treatment and episodic cluster headache, and also since the end of 2018 it has been also approved for prophylactic purposes as well. Again, it's a non-invasive vagus nerve stimulation that patients administer themselves. You can see how this GammaCore device looks in front of you. Essentially, patients palpate the carotid pulse and they apply this gentle stimulation to this area. The stimulation is not painful. Patients do experience very mild paresthesia and a little bit of twitching of the muscle in the corner of their mouth. And that basically an indication that we're delivering enough of the stimulation to engage and capture the fibers of the vagus nerve. And this therapy has been shown to be very effective as a rescue therapy for migraine and as well as the cluster headache as a rescue and the prophylaxis for that matter. Another non-pharmacological treatment option available for our patients is the transcutaneous supraorbital nerve stimulator, which is also a non-invasive device known under the brand name of Cephali. This device has been approved for both prophylaxis and as a rescue therapy for patients with migraine headaches. If patients using it prophylactically, they apply the stimulation in the middle and lower portion of the forehead, almost like between their eyebrows and the vicinity of the transcutaneous, in the vicinity of the supraorbital and supratrochlear nerves. Prophylactic therapy consists of 20 minutes of stimulation that patient needs to apply by themselves every single day prophylactically, or they may use it as a 1 hour long stimulation at the onset of the migraine headache, and that's a rescue mode. At this point, there are 3 different devices available. The first device is approved only as a rescue therapy. It has only rescue type of stimulation modality programmed into it. The second device is used only for prophylaxis. And finally, there's a dual mode device, which is in front of you on that slide, that actually can be programmed to deliver either acute or prophylactic therapy. Patients do experience mild paresthesias that starts as a very mild sensation, and during the course of that 20-minute stimulation, it increases in intensity. It becomes a little bit of unpleasant by the end, but it's still very manageable. And most of the patients who can use this device for more than 1 week at a time, they typically would tell you that this paresthesias become less and less uncomfortable for them. So it's really important to use this device daily, and it may take sometimes 2 to 3 months for them to start seeing significant improvement in their headache frequency. With that being my final slide, I hope that this presentation was informative and helpful for you, and I wish you all the best.